Discussion session 5, risk stratification. Now, Dr. Lambiase, you have an international reputation in regard to syndromes. You'll be particularly well placed to talk about some topics here, but also I know, Professor Riccio, you would have some input on ICD and CRT as well in this discussion, but I'm sure you'll have plenty to say. Dr. Lambiase, would you like to start with what is your opinion on the risk stratification of Brugada syndrome?
Right, okay. I mean, this is obviously a very broad topic, and essentially over the past few years we're starting to see some convergence in the data that's coming from large registries and also a recent randomized controlled trial, the PREU trial. And so I think what we can confidently say is that if you have a patient that has symptoms with syncope and a type 1 resting ECG, they're at high risk of ventricular arrhythmia. Of course, that's based. All the registries and trials seem to converge and agree on that point. The problem's really arisen from using risk stratification tools, principally VT stimulation studies, to try and identify the asymptomatic patient. And the concern we all have, of course, is if that patient, maybe their first symptom could be a cardiac arrest. Now, early on, particularly from the early Brugada data from the Brugada group, they had a very high risk of ventricular fibrillation in their population when the VT stimulation study was positive. Now, that hasn't been borne out in the larger registry studies, and there have been questions about the fact that the initial populations probably had more severe disease, and the fact that a VT stimulation study has a very low and sensitivity and specificity. In the recent Prelude trial, 40% of the patients had inducible VF, and yet the event rates were very low, and that's borne out also in the registry data from the finger registry. And also the reproducibility of the VT stimulation study is poor as well. So it's looking very much now as if a VT stimulation study is not going to be a helpful risk stratifier in the asymptomatic patient in the wider populations that we have. What has come out of the recent data is that if the refractory period within the ventricle is very short, less than 200 milliseconds within the ventricle, that seems to identify a higher risk group. And also if one sees late potentials or fractionated electrograms on the surface ECG, that also seems to identify a higher risk group, and that's been borne out in a couple of other smaller studies. So I think if one approaches a patient with a resting type 1 ECG, I think there is still going to be a role for a VT stimulation study or an EP study, one to evaluate whether they have a short refractory period within the ventricle, and also to look at whether there are markers of conduction delay and fractionation. When the patient's sitting in front of you in the clinic, the discussion I had up until probably 6 months ago was we could do a VT stimulation study, and if it's negative, it may suggest that you're at lower risk than if it's positive. But now we can't be even confident about that. So at the moment, what I recommend is that primarily to discuss the options of the EP study to see if we can learn more about the condition and their risk to contribute to larger registry data. And for the individual patient to counsel them very closely about any evidence of symptoms. So if they have pre-syncope or obviously a syncopal event, they must report that immediately, because that could be a marker that the disease is changing or they're at high risk. And also the avoidance measures they need to take. So there are a list of medications, including beta blockers, calcium channel blockers, that need to be avoided in these patients because they increase their proarrhythmic risk. Just like in long QT syndrome, there are numerous drugs to avoid. And also if they develop a fever, they're known to have much higher risk of ventricular arrhythmia. So we're now recommending they come to hospital if they have a fever to be evaluated.
Yeah, one question, Pierre. You talk about the fact that symptoms are so important. Then does an asymptomatic patient exist?
Well, you're saying they come to clinic and sometimes I feel a little bit dizzy, a little bit lightheaded. I mean, it's a bit like the asymptomatic Wolff-Parkinson-White patient, isn't it? You know, until they had a delta wave on their ECG, they didn't have any palpitations.
So in fact, what you're talking about is patients that have no symptoms, that are asymptomatic, but that have a Brugada type 1 ECG in there.
That's right. So, and those are the patients that really one has to monitor carefully and make them aware of what particular symptoms to watch out for. Because we're essentially at the end of the day, we're balancing the risk of long-term morbidity with an ICD against the small risk if they're asymptomatic of ventricular fibrillation. And of course, the main problem is the weighting of the fact that a VF arrest is such a negative outcome that the morbidity issues maybe don't weigh as heavily against that. But we're talking about people in their 30s, 40s, 50s, and you're talking about 20, 30 years of device complications potentially.
You talked about the short ventricular refractory period.
Yeah.
Is that measured in the apex or the outflow tract?
So that was measured during VT stims either from the apex or the RVOT. In the prelude trial, they looked at both sides, and if it was less than 200 milliseconds, that group had a higher incidence of developing VF, which actually makes sense electrophysiologically, mechanistically. That.
Okay.
Pierre, in the light of recent report of Dr. Nademani about ablation epicardially, with some structural changes they could prove using mapping, how you feel about using some imaging modality to pick up some high-risk individuals, especially in asymptomatic ECG pattern?
Yeah, I mean, that's a very interesting question. I mean, imaging the right ventricle for fibrosis is extremely demanding. It's probably as if only fractionally less demanding than looking for fibrosis in the left atrium, because the RV wall and the outflow tract is only about 2 millimeters thick. So you're trying to resolve fibrosis in the epicardium.
But there might be also some dyskinetic areas or some aneurysms or whatever.
Yeah, I mean, there have been studies looking at Brugada patients with MRI, and most of the studies have not seen structural changes. There's one large MRI series in the European Heart Journal, which was published in the European Heart Journal, which showed some RV outflow tract dilatation. But how that would impact on prognosis is a completely open question. And that's assuming that we think that Brugada is one disease. I mean, essentially, Brugada is an ECG manifestation, probably of either ion channel diseases or structural heart disease, such as a form of right ventricular cardiomyopathy. So it's actually a spectrum of disease. And we're really still at the stage, I think, of trying to classify which group of patients actually fall into each part of the spectrum.
Can we clarify, I mean, by type 1 ECG, you mean type 1 all the time or intermittently? Because, of course, there's transition. And, of course, the large majority of our patients are patients who have a Brugada type ECG that may be 2 or 3. And our challenge is, what do we do with them and what do we advise them? And is there a role for adrenaline anymore? Because if we're not acting on the results of the adrenaline study, what's the point in doing it in the first place?
I think the adrenaline test is still valid because, first of all, if you have a patient with a type 2 or type 3 ECG and it converts to a type 1, that's an indication they have the potential to have the full Brugada phenotype. And also it's relevant because it's going to affect what medication you recommend they avoid. And if they were to develop a fever, for example, certain antibiotics to avoid, and also to be in hospital the first time to make sure they don't have runs of ventricular tachycardia with fever. So I think it is relevant to know that the patient has the phenotype, has Brugada.
So if they have a negative adrenaline test, would you say that means they're clear? Because there's, as I understand, there's an 80% sensitivity for adrenaline, is that right? So if they don't have a negative...
85 to 90%, yeah. I think essentially if it's a negative adrenaline test, I tend to reassure the patient. I mean, it may be that if there's a family history of Brugada syndrome, it's an open question, should you repeat the adrenaline in 5 years' time to see if there's been progression? And that is still an open question. But the fact that the adrenaline is negative automatically puts them into a low-risk prognostic category.
Should we move on to your views on the safety, efficacy and reliability of subcutaneous ICD? Professor Riccio, would you like to start?
Well, this is a really big question.
Yes.
And it's a big question because I think most of the data collected so far are really related to relatively small series. So I think that we have to acknowledge the fact that the technology is extremely interesting one. I think everyone will agree that to have less lead in the body, so in the vascular routes, is really not the most ideal one. And I think now is a strong need to reduce, first of all, the number of implanted leads in general. And I think the most recent report by the Durata lead shows that how important is, so abrasion from previous left lead in the body is so important. So meaning that this probably will increase the threshold for extracting, but more in general, I would say that there is for sure is the need to to stay out of a vascular system. Now, whether the subcutaneous ICD, the current one, is the right solution, I think this is one technology. And we know, I have to say also relatively little about that, because we know that this for sure is efficacious. I mean, it is able to terminate VT and VF acutely. I may have some personal doubt about also lead performance in terms of long-term data. We don't have enough data or long enough that really can be so reassuring also in that sense. And then the question is obviously when you put a device like that is this is really we are losing part of our ability to control some of the more VT phases, which is mostly able to be terminated by ATP or ATP functions. So unless our technology is becoming more and more or able to provide endocardial leadless pacing combined with ATP, combined with the subcutaneous ICD, I think that, at least for my personal point of view, I will really think to use subcutaneous ICD probably in a subset of a population which may be really the one, maybe the young one, in which the likelihood to have really VT storm, eventually primary prevention. So again, where you don't have very much scar, essentially. So we're talking about Brugada, we are talking about young patients again. I think those are probably the one who for me might be considered for this kind of a technology. Again, the fact that we don't have data on the other and largest group of patients does not mean that it's not indicated, but currently I don't have the answer to that, honestly. And there is also many other important information that most of the subcutaneous ICD, they do not have remote monitoring. So we are losing another very important component of our, I would say, established practice to follow patients. And this is really quite important because I think this is where most of our reliability and I would say daily practice now is based on. So to unload our outpatients clinic essentially. So this is my personal view and personal point.
Angelo, do you believe that we need to go into randomized prospective studies comparing the subcutaneous ICD with standard ICD technologies in order to prove equivalence? If we look to the data that we currently have, you made that point, there are very, very few prospective hard data, even fewer completely independent data. We will see a couple of manuscripts coming out soon showing that these devices may have problems, especially in the patient population. They have been designed for the channelopathies, sensing problems, or the detection algorithms. Do you think we should go into these studies, or do we need these studies in order to approve this technological?
Well, certainly I think we do need to have those studies. And the study is not to show mortality benefit. I don't think that is probably what we are aiming. I think we have to say well, at least to have efficacious and safety. This technology have to be as safe as reliable as, and as efficacious as. Again, I'm not expecting to have another MADIT 2 or any other kind of SCADEF trial to prove that this technology is really the one that can be widely spread or widely approved. But at least I have to think that this is really the key point. So comparative assessment is very, very important. And also because I think this technology, again, has an intrinsic advantage, and I think the intrinsic advantage is related to the fact that you don't have leads in the body. So if you put also this component of related, but with more the long-term performance of a system. So you say, well, how frequently I have to, or I can leave a lead in, so the lead performance, because this is an integral component of the subcutaneous part. So if you say, well, a lead performance, the best we have these days is, let me say, 90% at 5 years or 7 years. and with a subcutaneous implantation, I have an equal lead performance, because this is the other part. Is not only the efficacy of the defibrillator, but it's also the lead performance, which is also not clear. This is another kind of comparative assessment that I think is important, because at the end of the day, economic data, because again we are talking early on today about the cost effectiveness of this therapy compared to the other one. I think if you want to say, well, this is really a technology, is a therapy which costs us, but in terms of long-term perspective, so we have a patient's 20 years treated, because that is what we are talking about. We need to have really good data showing that, doing with a simple device is as good as what we have when we have a standard VVI defibrillator implanted.
At this stage, I see more disadvantages than advantages.
Again,
in general population of ICD, I'm not talking about patients who have infection, for instance, or who have a problem with venous access. But at the moment, I see more disadvantages. Namely, you cannot use pace termination. You cannot use pacing, antibody pacing. Half of our ICD population in our center is are patients with CRT. So this is another issue, and long-term data are not existing, and the device is not any smaller, price is not any significantly lower. So at this moment I see really no major incentives to use technology except of some niche indication. This is my opinion.
I have the same position, and I don't see the need for equivalence trial, honestly, because I can never believe they are equivalent. If
you cannot believe?
No. If you think logically, they can never be as safe and they can never be as effective. Because
but Hein, when you come with a technology like this, I mean,
exactly,
it is our duty to say, well, show me that it is.
But what I think where the benefit lies, as you laid out, is in the long term. So I think that indeed we should implant them in larger groups of really niche patients where a subcutaneous approach is the only approach possible, and then look what is the long-term performance of these devices. Only if we see a benefit there that indeed they have less lead complications in the long term and their performance is comparable to what we have in historic regular ICD populations, then I think the time may be ripe to really compare them in a head-to-head basis. But at this moment, I honestly think that logic tells us that when you don't have sensing in the heart, you can never be as good, and that means that you will under-detect sometimes and you will over-detect at other times.
I mean, from the data so far, from the effortless registry and the IDE registry, there have been the inappropriate therapies that have occurred have been in the VF zone, because there's no SVT discrimination in the VF zone of the device, because it only relies on rate. In the conditional shock zone, the algorithms have successfully distinguished between SVT and VF in those registries, but we're all very aware that there are a limited number of patients where there have been oversensing issues, and there's been about 3% of the inappropriate, there were 7% of patients had inappropriate therapy, and 3% of those had T-wave oversensing issues. And I think the critical thing is with this new technology is it does offer a significant advantage over the morbidity associated with the device. But at the same time, we've got to be extremely careful with the identification of the patient most likely to benefit, and we exercise the patients with the device to make sure they don't have oversensing issues, because a lot of our patients are very young. And I completely agree, patients with Brugada and non-QT, probably positional manoeuvres have to be undertaken as well to minimize this oversensing problem.
No, but I think we all agree it's amazing technology and that it performs as it performs nowadays, but I still think it's reserved for a niche population of patients, and it's a fantastic option to have that in those patients.
If you had a patient with ischemic heart disease, say a MADE-IT2 type patient who has a narrow QRS, and you want to implant an ICD, would you consider doing say it's a relatively young patient in their 40s, would you consider doing an EP study and seeing if they had inducible VT? And if they didn't have an inducible monomorphic VT, would that change your opinion as to whether you put a sub-Q device or a
No.
standard device in?
Honestly not, because if the patient has an old myocardial infarction and there is scar, I know that scar will be evolutive over the years, and it's not because I cannot induce something today that there will be no monomorphic VT in 5 years, and then anti-tachypacing may be helpful. So, and I'm concerned about long-term psychological effects, because inappropriate shocks can lead to a situation where the patient is not trusting a life-saving device anymore, and we all have that sort of patients where we have to talk very hard to keep the ICD on board. And I think that is a scenario that will undoubtedly be more common with the subcutaneous ICDs.
But on the other hand, I think, when we talk about, because your question goes, I think, a little bit also beyond that particular situation, we say we have now data on prophylactic VT ablation, because that's what we have. So now, if you consider that the possibility of having a strategy to have a prophylactic VT ablation, I don't know what you do, we don't do, but if you say, well, now we have with the reasonable, or we are, I think, good enough to think that we have ablated a substrate, so the likelihood to have a VT is gone, because that is where the major concern is coming, and where you don't need to use ATP, if you like. Say we are only treating the VF component, because that's what we are coming to. Would that be enough for you? Or again, the combination of ablation, prophylactic, and then subcutaneous ICD?
Yes, but I'm concerned that there may be inappropriate detections and shocks, and that this may compromise also the quality of life of the patient. And I'm not so sure that this pays off in the long term well enough versus the lead-related complications, which definitely are a problem. I do not negate that, and I stimulate the further research in the subcutaneous ICD, but for me the time is not come yet to consider it as an equivalent option.
But you're saying, hang on, you're assuming that ICD therapy doesn't have inappropriate shocks, and that's completely inaccurate. I mean, you're trying to say that this technology, because it has a 7% inappropriate
even
shock.
with regular ICDs, we have still too many inappropriate shocks.
Exactly.
Yeah.
But I think that a lot has been done to reduce that. I mean, I think that relying less on SVT discrimination algorithms, setting very high detection rates, remote follow-up to detect impedance problems are all going to be huge, make huge inroads into that problem. And I think that your point earlier on, that whatever the substrate for their VT, it's not static. Ischemic heart disease, they develop further coronary disease. Dilated cardiomyopathy, it's progressive. So whatever your VT ablation does, or your EP study does on that day, 3 or 4 years down the line, it may be a completely different substrate.